Welcome to Road to 250. Today we'll talk about the platelet plug for primary hemostasis, platelet disorders, and then I'm going to talk about drugs. And there's 3 classes of drugs that we'll cover today. And then there's some review questions. So when you think of a thrombus formation, when you and when you have endothelial damage, there's 2 routes that it's going to take. Either it's going to go the coagulation cascade and make fibrin to make a thrombus, or it goes activates platelets to make a thrombus. So today we're only going to talk about this. So platelets are small cells that are derived from megakaryocytes, and they don't contain a nucleus. So their lifespan's about 8 to 10 days, and its production is regulated by thrombopoietin. Thrombopoietin is a glycoprotein that's produced in the liver, and the job of the platelet is to aid in hemostasis after vascular injury. They circulate in the blood in an inactive form, and then can activate via endothelial injury or stimulus that are released from other platelets. And we'll talk about those in a few slides. So activated platelets, basically job is to seal damaged vessels. So the actions of the platelets will be adhesion to subendothelium, aggregation, platelet to platelet binding, and then their other job is to secrete. They do secretion, and they release granule content. And these platelets are activated again by binding to subendothelial collagen, and they stimulate by activating substances. So the more secretion of the stored activators, the more activation it has. So there's 2 types of platelet granules. Can you guys name me the 2 types of platelet granules? All right, so there's alpha granules, and then there's
like
dense
fibrin.
So I'm just talking about the general subclass, and then within these guys, they have other contents. So yes, fibrinogen is one, and then von Willebrand's factor is another for the alpha granules, and then in the dense granules, it's ADP and calcium. So typically, when you look at just a general picture, is you have an exposed subendothelium, the platelets are flowing, and basically you have adhesion and aggregation, and then they secrete to basically find more platelets. We'll talk about all these steps shortly, but this is just a general overview. So this is directly from first aid. You can see it's involved in primary hemostasis, and basically small cytoplasmic fragments that are derived from megakaryocytes. They are about 8 to 10 days, and they're activated by endothelial injury or interaction with fibrinogen to form the platelet plug. So they have the dense granules, which again do ADP and calcium, which I'll talk about, and then the alpha granules, which have von Willebrand's factor, fibrinogen, and fibronectin. Thrombocytopenia or decreased platelet function results in pectinate. Talk about that. And then von Willebrand's factor basically meets up with the glycoprotein GP1B, and then fibrinogen receptors have the GP2B3A. And again, we will go through those more in detail. So von Willebrand factor, what is it? It's a large glycoprotein that is synthesized by the endothelial cells and megakaryocytes. So we just said the platelets are derived by megakaryocytes. So you could see that von Willebrand's factor is not only in the endothelial cells, but they're also present in the platelets within our body. I should turn that laser pointer off. So where is it stored in the endothelial cells? Can anybody tell me? And the Weevil Palati bodies. And what else do these bodies release? Does anybody know?
Vasopressin. I mean, factor 8.
Okay, so you're thinking about von Willebrand factor that's attached to factor 8. That is correct, in a sense, but these bodies release something specific. It's part of the inflammation process. It's P-selectin. So P-selectin is also released from these bodies, and they're used in inflammation. And the von Willebrand's factor is released on any vascular injury. The membrane glycoproteins are basically amino acid and glucose molecules, and they're found on surface of platelets, and they interact with other structures and molecules. So they're important, and the examples are GP1B or GP2B3A, which they come into play a lot in this lecture. So when we talk about platelet slug formation, we want to see that if there's an injury or the endothelium is damaged in any way, you're going to get a transient vasoconstriction, and that's due to neural stimulation as a reflex. And then exposure is von Willebrand factor will bind to the exposed collagen, and basically it's seen here, von Willebrand's factor is from the Weeble Palade bodies of the endothelial cells, and then the alpha granules of the platelets. So that's where they're stored in. And then once these platelets bind to the von Willebrand's factor, they'll bind via the GP1B receptor. So in simple terms, you have vascular damage, exposes the collagen, and then the subendothelial collagen binds to von Willebrand's factor, and then von Willebrand's bind to the GP1B on the platelets. And then platelets will release ADP and calcium, and these are necessary for the coagulation cascade, and then thromboxane A2. Again, we'll talk about these two in the next slide or two. But this is a picture when you have a subendothelial collagen is exposed. First, the von Willebrand factor is going to bind, and then the GP1B receptor on the platelets will bind. I'm going to talk about these platelet plugs in step by step, and then there's a picture at the very end where we'll talk about everything. So adenosine diphosphate, which ADP, it's released from the dense granules, and it binds to two G protein receptors, P2Y1 and P2Y12. These basically leads to decrease in CAMP and phase formation inside the platelets, and then they activate the platelets. So ADP is a potent platelet activator. So it does it by decreasing CAMP. And then there's a class of antiplatelet drugs, which we'll cover towards the end, that are phosphodiesterase inhibitors. And what they do is they increase CAMP, thus blocking platelet activation. So this is how these sets of drugs, this is their mechanism, essentially. So what does the P2Y receptor, or P2Y1 receptor do when it's activated? It basically releases calcium and changes the platelet shape, and then P2Y12 is a platelet degranulation and increases aggregation. So as it says here, the ADP, which binds to the P2Y12 receptor, induces the GP2B3A expression on the surface. There's a better picture towards the end, and like two or slow slides, which will show that, and then that will increase the aggregation process, which is next. So fibrinogen basically binds to the GP2B3A receptor and links platelets. So platelet aggregation is mediated by GP2B3A, and it can use fibrinogen as a binding factor or von Willebrand's factor. So the way I think about this is, imagine you have a platelet with that receptor. Essentially, it can't meet another platelet with that receptor directly. It needs something in between, and that's going to be either your fibrinogen or von Willebrand's factor. And once that's present, essentially these two will bind, and then that's how the platelets link to each other. The basis, this is also where you can use the 2B3A receptor blocker drugs here, which we'll talk about. So thromboxane A2, as it's listed here, it's a powerful platelet activator, and it's found on platelets and then also on the red blood cells. So this is released when there's a red blood cell damage or you have endothelial injury. Basically, it's derived from lipids in the cell membrane. We have phospholipase A2 as the enzyme, and then that converts it to arachidonic acid. And arachidonic acid is at the sites of vascular injury and is also stored in platelets. And as we all know, arachidonic acid can be converted to thromboxane A2 via cyclooxygenase, and that will activate more platelets. So if this is a pro-aggregation factor, is thromboxane A2. Now, if you have prostaglandin I2 or nitric oxide, which are released by the endothelial cells, it's anti-aggregation, so it's not going to basically form a plug. And then aspirin, which is another drug, inhibits the cyclooxygenase enzyme, decreasing thromboxane A2, and that will decrease, basically, it's an inhibitor of the platelet activation. So this is the picture that I was talking about. This has all the steps that we just covered, essentially, but von Willebrand's factor binds to the subendothelial collagen. GP1B receptor will bind to it with a platelet. And ADP, as you see here, when ADP binds to this receptor, it brings out the GP2B3A onto its cell surface. And then you have fibrinogen, which can essentially bind and link up other platelets. And then inside the platelets, you have von Willebrand's factor. You also have fibrinogen. And then arachidonic acid is also present, which can convert it to thromboxane A2, which pretty much brings in more platelets. Now, you'll see in certain spots here, there's a deficiency of this receptor, or there's deficiency on von Willebrand's factor. They'll lead to certain diseases, which we'll talk about in the next few slides. So this is just an overview slide of everything. And we are going to talk about these drugs later, but they're here. So this is basically an overview slide. Does anybody have any questions up to now?
No.
Cool. All right, so let me get 1 second. Make sure I'm set. All right, so we're going to talk about bleeding disorders and the different types of bleeding. Bleeding disorders are either due to abnormal platelets, you have abnormal coagulation, or then there are certain things like mixed disorders. So what we're going to cover today essentially are just these sets of guys here. And then obviously these are both coagulation and platelet disorders. And I'll briefly mention DIC because it comes up a little bit. And can't click. All right, so there's types of bleeding. With an abnormal platelet dysfunction, your bleeding problems are superficial. So you get mucosal bleeding or skin bleeding or pectine. And then there's abnormal coagulation. When there's an abnormal coagulation factor, then you're going to get more of the joint bleeding or deep tissue bleeding. And a test that we commonly in the past used to use is a bleeding time, but the way that the bleeding time was done in the past is no longer used. But essentially what bleeding time tests is platelet function and see if the platelets are working. So what we're going to talk about are inherited platelet disorders, and these are basically passed down. And these are the three that we're going to cover, and then there's acquired ones that we'll cover. So the first one is Glanzmann thrombocythemia. It's an autosomal recessive disorder, and it has a functional deficiency of the GP2B3A receptor. So that receptor generally allows for platelet-to-platelet aggregation. So if you have a deficiency in that, essentially it's not going to allow the platelet-platelet to bind together. So there's not going to allow the platelet-platelet aggregation. So it often results in bleeding and epistaxis. And the key diagnostic findings that you're going to look for in a patient who has this will be a prolonged bleeding time. And if you look at the blood smear, you're going to just see an isolated platelets. There will be no clumping of platelets because they can't clump together because of the deficiency of this receptor. And you can do a test to see if they'll respond to stimuli. And that's when you have the platelets and you mix them with ADP or arachidonic acid, but they won't respond with the aggregation, again, because they're still deficient. So this is just from first aid, just to basically reiterate what I said. And you're often going to see increase in bleeding time. But your platelet count may be normal right here. So any questions about this one? Cool. So we're going to talk about two simultaneously. It's the Bernard-Soulier syndrome and Wiskott-Aldrich syndrome. So Bernard-Soulier syndrome is, again, an autosomal recessive disorder. It has a deficiency in the GP1B receptor, and the platelets cannot bind to the von Willebrand's factor. So the key lab findings in these patients will be prolonged bleeding time, thrombocytopenia, and for some reason or another, you're going to see large platelets on smear. As to why that is, I don't know. Nobody knows. I don't know if they know, but this is a common sight that you will see on a smear. So essentially that's there. You're going to see large platelets, and there's a defect.
Wait, were you saying why there's large platelets?
I really don't know the mechanism behind it. I tried to look it up, and I couldn't find anything as far as why you see large platelets on the smear.
So I think it's because GP1B receptors connect to, like if you go back to the picture of the mechanism from the first aid.
Of GP1B? This one?
Yeah. Yeah. So you see the two platelets, and then hold on.
So the
I guess I always thought it was because
your platelet formation between these cells is still going to be there. It's just not going to be able to adhere to the subendothelial lining. So you're still going to see your platelets in circulation. They're just not going to be stuck in that spot, if that makes sense.
Yeah, and they still might have the GP2B3A receptor still works, so it could be like large platelets clumped, but not stuck to the endothelium like it should be.
Yeah, so there's no problem with platelet formation.
Mm-hmm. And I think they're large because the GP2B3A receptor is still active, so you can have like those two platelets still like floating around, hence why large.
Okay, that makes sense to me. All right.
Thanks for going back, because I did a little.
All right, so Wiskott-Aldrich syndrome is an immunodeficiency syndrome in infants. It's an X-linked disorder of the WAS gene, and it's basically the WAS protein that's missing, and WAS protein is necessary for T-cell cytoskeleton maintenance. So the triad that you normally see in these patients are immune dysfunction, decreased platelets, and eczema. That's pretty much it from what I got, and the only reason it's here is because you'll see a decrease in the platelets. So that's why it's an important one. So immune thrombocytopenia is basically an acquired platelet disorder. The disorder, somehow they decrease in the platelet survival, and they're commonly because they have anti-GP2B3A antibodies, and because they have these anti-GP2B3A antibodies, they're basically consumed by the splenic macrophages. So the diagnosis for immune thrombocytopenia is based on exclusion. You want to rule out any other cause of bone marrow suppression, and the treatments will be either steroids to knock down the production of these antibodies, IVIG, which basically what they do is they block the FC receptors of these macrophages so they can't eat basically these antibodies, or splenectomy. So in first aid, what I described in my writing is basically a primary or idiopathic way of what's happening, but it can also be secondary to autoimmune disorders or viral illnesses. I've seen many questions about viral illnesses, and they basically give you low platelet counts and other symptoms to lead you to immune thrombocytopenia. So you want to make sure that you also know that it's secondary to other autoimmune disorders. And then in labs, you're going to see increase in the megakaryocytes on bone marrow biopsy. And then the treatments are the same. All right, and then we'll move forward to, oh, by the way, the ITP is an acquired disorder. It's not an inherited disorder. So just an addition there. TTP, or thrombocytopenia purpura, is a disorder of a small vessel thrombus formation. So this is basically consumes your platelets and leads to thrombocytopenia. And it's a decreased activity of the von Willebrand's factor cleaving protease Adams TS13. And so von Willebrand factor is synthesized as a protein monomer initially, and the monomers are linked in the endoplasmic reticulum to form dimers. And these dimers then go to the Golgi to form multimers. So it's a multi-step process. And these multimers are then either stored in their Whipple-Palade bodies or the alpha granules. So when these multimers are then released into plasma, if you don't break them down, then there'll be a bunch of these guys, von Willebrand factor, and it basically blocks the blood flow. It obstructs the blood flow. Oh, and Adam TS13 basically prevents that obstruction. So it's a metalloprotease enzyme, and what its job is to break down these multimers of von Willebrand's factor to prevent thrombotic occlusion. So here's a picture. So normally you have von Willebrand's factor that's in these large multimers. As you see here, they're clumped up together. So when they come out, Adam TS13 enzyme breaks these multimers down so that it basically does not obstruct. It doesn't form that multimer, and it's broken down into monomers. But if you have TTP, basically you have a deficiency in this enzyme, and that will lead to these von Willebrand's factor still being clumped up and causes occlusion. So it's TTP is normally due to severe Adam TS13 deficiency. So usually this is when you have less than 10% of the normal activity of this enzyme. And its usual cause is due to an acquired antibody or autoantibody to the enzyme Adam TS13. So it results in von Willebrand multimers in high shear stress, usually in the small vessels. So when the small vessels are obstructed, it can cause microangiopathic hemolytic anemia, and these occur due to shearing of the RBCs as they pass through the thrombi. So when you do a blood smear of a patient who has microangiopathic hemolytic anemia, you would see schistocytes. So that's the key that you want to see here. I'll have a picture for you later. And the symptoms of TTP are basically fever. You're going to get neurologic symptoms, such as headache, confusion, or seizures. And the fever is because your inflammation of the small vessel, occlusions, and tissue damage. So that's why you're going to get a fever. You get renal failure, and you can get pectinate and bleeding. Lab tests that you will see are hemolytic anemia, thrombocytopenia, and cystocytes on smear. Your PT and PTT are going to be normal in this case because you're not using anything of the coagulation factors. It's not getting broken down. Contrast to DIC, which again does small vessel occlusions, but in those small vessel occlusions, it's because it's affecting the coagulation pathway, and that's why you're going to see abnormal PT and PTT in those patients. However, because you're forming a thrombi of a sort, you can get elevated D dimers. So you may see those. So this is from first aid. Again, your platelet counts will be low, and then your bleeding time will be high. And it's due to the deficiency of the Adam TS13, and it's a metalloprotease enzyme. So on pathogenesis, it's large multimers, increase the platelet adhesion, and then the aggregation and thrombus is increased. So labs will be cystocytes. Oh, and the key one here is an LDH, but your coagulation parameters are normal, so your PT and PTT are also normal. And this is microangiopathic anemia. Its RBCs are damaged when passing through the obstructed or narrowed vessel, and these you'll see in DIC, TTP, HUS, and other symptoms or other conditions. And cystocytes or helminth cells are seen on peripheral blood smear due to the mechanical obstruction or destruction. So any questions about this one? All right. So hemolytic uremic syndrome, or HUS, has many similarities to TTP. It also is caused by a platelet-rich thrombi in small vessels, but it's commonly seen in children, and it's commonly following a GI infection of E. coli 015787, or a Shiga-like toxin that causes microthrombi. And so the symptoms you're going to see are, again, microangiopathic hemolytic anemia, thrombocytopenia, and you can have acute kidney injury. However, you're probably never going to see a fever or CNS symptoms, and this is how you can differentiate it with TTP, because it's so similar, but you're not going to see fever or CNS symptoms. So, again, pretty much what I've covered, and HUS is seen in children. It's accompanied by diarrhea and the Shiga-like toxin. However, in adults, it's not present with diarrhea. And the EHEC infection is not required. And you're going to do initial treatments and treat with plasmapheresis. So this is a little, review diagram or review chart that I have that I really did like. With ITP, all you're going to see is decrease in the platelets, but none of these other, you don't have hemolytic anemia or PT or PTT. With TTP and HUS, you know that it's a platelet thrombi, not a coagulation. So with DIC, you have platelets, but you also have fibrin thrombi, so it's your coagulation pathways affected. And that's why with this one, you're going to see your PT and PTT are going to be increased with DIC. With TTP and HUS, you're going to have hemolytic anemia as well as with DIC. But with TTP, you're going to see fever and confusion, which is not often seen with HUS. And with HUS, you're going to see it in a child or with a GI illness. So if it helps you keep in track, this is a good review chart. So any questions before we move on to the set of drugs for the night? Cool. So we talked about activated platelets, and basically when you have endothelial damage, it can go multiple ways. So there's a lot of drugs that we can use in pharmacology to basically block the thrombus formation. So when you have anticoagulants, you can have anticoagulants such as heparin, warfarin, which we're not going to cover today. All we're going to focus on today are going to be the antiplatelet drugs, excluding aspirin, because I think we've covered NSAIDs in a previous lecture, so I'm not going to really cover aspirin or NSAIDs today. But we will talk about the ADP blockers, the 2B3A inhibitors, and your phosphodiesterase inhibitors. But this kind of gives you a general view of how things are broken down. So your ADP receptors inhibitors include your clopidogrel, prasugrel, ticlogrel, and ticlopidine. So they basically inhibit the platelet aggregation by irreversibly binding to the ADP receptor or your P2Y12 receptor. I think ticagrelor is the only one that's a reversible one, and so that's not going to do irreversible blocking. And basically prevent expression of glycoproteins 2B3A on the platelet surface. So by blocking this, you're blocking this, and you can use this in acute coronary syndrome, coronary stenting, and decrease incidence or reoccurrence of thrombotic stroke. Am I missing anything else? So with adverse effects, you can see TTP as an adverse effect, and then obviously bleeding could be another one. And sometimes these drugs are added to aspirin for prevention of MI and stroke. With ticagrelor, there's a unique side effect of dyspnea. The mechanism of why that occurs is unclear, but there have been studies that show that patients do have dyspnea when taking that medication. So any questions about this drug? So we're talking about the glycoprotein 2B3A inhibitors. So excuse me, I try to get the drugs down. I know I'm probably going to screw it up, but epsiximab, epifebetide, And triofibin are the drugs that are in this class, and they bind to the glycoprotein 2B3A on activated platelets, preventing aggregation. And abciximab, is made from monoclonal antibodies of Fab fragments. So clinically, you can use these drugs for unstable angina, precutaneous coronary interventions, and adverse effects are bleeding and thrombocytopenia. Any questions about this drug? All right, so the last set of drugs before our review questions are your phosphodiesterase inhibitors. As I had mentioned earlier, these are going to be your silestazole and dipyramidol. Basically, they're phosphodiesterase inhibitors. They increase CAMP in platelets, and that results in inhibition of platelet aggregation. And they're potent vasodilators. So when you're talking about these drugs, we're going to talk about silestazole real fast. Not only does it it increases the CAMP in the vascular smooth muscle, so that's how it has this vasodilation effect. And it's rarely actually used for its antiplatelet effects, and it's used mostly for its vasodilatory effect. And it can be used in peripheral arterial disease, so it increases the blood flow to the lower extremities and decreases the symptoms of claudication. And this dipyramidol is, again, a phosphodiesterase 3 inhibitor. It inhibits platelet activation, but also blocks adenosine uptake by the cells. So adenosine, as we all know, is a vasodilator. So when you block the reuptake, it basically increases the levels of adenosine, and that's how it causes its vasodilation. It can be used with aspirin to prevent stroke, and that's how it's used in its antiplatelet effect. But it can also be used for cardiac stress testing, and that's how it's used in its vasodilatory effect. And if you know that they're vasodilators, you can easily know the side effects. So it can cause headache, flushing, and hypotension because it's a vasodilator. It can also cause nausea and abdominal pain. So any questions? And this basically is a review slide from an inactivated platelet to activated platelet. You can block it via these three drugs or drug classes. And once it's activated, you can use the 2B3A receptor blockers, essentially, to block platelets from aggregating. So any questions before we move on to our review questions? Okay. So here we have a 44-year-old woman that presents to the clinic with a low-grade fever, fatigue, and headaches. Although these symptoms have been present for a few days, review of her systems is otherwise negative, notable for no change in menses or frequency and quality of stool. Her past medical history is non-contributory. Today, her temperature is 100, blood pressure is 133/80, and pulse is 90. On physical exam, the physician notes mild scleral icterus and spots of pectinea on the extremities. Lab tests are obtained, and the findings are listed below. So her hemoglobin is 9, hematocrit's 27, platelet counts is 30,000, PT is 12, and PTT is 32. Peripheral blood smear shown right here. To confirm your diagnosis, you test which levels of the following proteins: bacterial toxin, clotting factor, cytoskeleton protein kinase, or metalloprotease.
E for elephant.
Okay.
Sure.
Sure?
Sure.
Okay. Yeah, the answer is E. This patient has microangiopathic hemolytic anemia, or MAHA, as they like to say it, and has thrombocytopenia and neurologic and renal abnormalities. And this pentat of TTP. And TTP have large multimers, and that. So you're gonna, because there's a deficiency of the atom TS13, which is the metalloprotease. Any questions? If you'd like, there's other answers here. So if not, we'll move on. So kind of an easier one. Several drugs are used to prevent myocardial infarction in patients with acute coronary syndrome. One class of drug binds to the glycoprotein receptor 2B3A on activated platelets, thereby interfering with platelet aggregation. This prevents renewed formation of clots, and that could block the movement of the cardiac vessel. Which of the following is an example of this class of drugs?
A for apple.
The answer is A. So they basically, pixiximab function is binding to the glycoprotein 2B3A. Clopidogrel and ticlopidine are the ADP pathways, so that's why those are wrong. And then the other ones are definitely not even involved. Any questions? All right.
I guess a way to differentiate or keep, straight in your mind between epsiximab and apixaban is that Eb6, it kind of sounds like 6, and GP2B3A, 2 times 3 is 6. Works for me, so maybe it could possibly work for you.
That's good. Anyone else?
And I guess like monoclonal antibody, so. And then the apixaban has the IX in it for factor
10.
10? Yeah. Yeah, 10A. Sorry, yeah. Not the IX, the XA. That's what I meant.
It has, they have the XA, so that's a 10A. So 10A.
Yes. Yeah. So.
Cool. Thank you.